my name is Alfonso Ielasi. I'm an interventional cardiologist based in Milan, Italy. It is my great pleasure to chair this webinar with the title Optimal PCI Therapy for Complex Coronary Artery Disease. My co-chairman will be Dr. Jiang. He's a deputy chief of the Department of Cardiology of the second affiliated hospital in Zhejiang University School of Medicine, China. We will have several presentations on complex PCI with new devices we can use in this kind of complex setting. So please, Dr. Jiang.
Okay, thank you, Dr. Ielasi. So according to the agenda, first we will welcome Dr. Vassilev to present his talk, Port and Alveo 0.975, new tools for the bifurcation lesions, please.
So I will share my screen, just a second. So please tell me if you can see the screen.
Yes, it's very good.
Okay, yep. Perfect. So in the next minutes, I will talk about POT and Alveo 0.75 balloons as new tools for the treatment of complex bifurcation PCI. So what does complex PCI means? There is not a universal definition, but if we look at several studies on this topic, there are some recurrent features defining complexity. In particular, bifurcations treated with 2 stents, CTO and unprotected left main PCI, treatment of calcified lesions, and treatment of diffuse coronary artery disease with implantation of more than 60 millimeter drug-eluting stents. Looking at the different subset of complex PCI, bifurcation PCI is that one associated with the higher risk of adverse cardiac events. So we must do every effort in order to optimize bifurcation PCI procedure to reduce ischemic event at immediate and long-term follow-up. So coronary bifurcation lesions must be considered as a vessel function structure composed by 3 segments: the proximal main vessel, the distal main vessel, and the side branch. There is not, even for bifurcation, a universal definition of complex anatomy, but if we refer to the most used classification for bifurcations, the Medina classification, we can consider complex bifurcations, the Medina 111 and the Medina 011, where both main vessel and side branch are involved. But beside to this fully anatomical definition, we must consider even other important features, in particular the clinical setting and the anatomical relevance of the 2 branches, the extension of the disease at the side branch, and the takeoff angle of the side branch, which can be associated with a difficult wiring in particular cases. So approaching bifurcation lesion, the mantra is to keep it simple and safe. It means try to implant just 1 stent in the main vessel, optimizing the implantation of the stent. As you know, the provisional approach is not inferior or equal to a systematical dual stent approach at 1 year follow-up in terms of a composite of death, MI, and revascularization, while it is associated with a lower incidence of target lesion revascularization at 3-year follow-up. So moving to the treatment of bifurcations with a provisional approach, a very important step is to decide the size of the stent, and usually it is decided according to the distal main vessel reference vessel diameter. So in order to optimize the apposition and to obtain a nice geometrical relation between the stent and the bifurcation, the so-called proximal optimization technique, POT, is of paramount importance in order to fully oppose the stent at the proximal main segment. This maneuver must be performed correctly and precisely. And now we have very important devices to do this step in a bifurcation PCI, before kissing balloon and after kissing balloon inflation. So what kind of benefits are associated with POT? The first, it is to achieve a full apposition of the stent proximal to the bifurcation and to correct eventual underexpansion, to preclude any unintended wire passage behind stent struts, to facilitate further access to side branch by any device used by pushing aside malapose struts, and to correct final stent deformation following kissing balloon inflation or side branch dilatation. So moving from theory to practice, I would like to share some cases of bifurcation PCI. This is the case of a diabetic male admitted to our unit because of effort angina. As you can see, there is a lesion on the first diagonal involving a second branch. Both branches were wired, but 2O semi-compliant balloon did not cross the resistant lesion, and even a fine cross 130 microcatheter was not able to cross the calcified lesion. So the BMW wire was exchanged with a rotafloppy wire, and rotational atherectomy with a 1.25 mm burr was performed. The first attempt was not successful. Then at high speed, the burr crossed the lesion. Then the lesion was pre-dilated with an Apollo non-compliant balloon 25 mm at 20 atmosphere, and a drug-eluting stent was implanted from the ostial diagonal to the mid-segment across the side branch. POT was performed, as you can see in the right side of the slide, using a 306 mm balloon at 14 atmospheres, and rewiring of the side branch was, of course, performed. Dilatation at the ostial and proximal segment of the side branch was done with a 2O mm semi-compliant balloon, and then repot was performed using a 306 mm balloon at 16 atmospheres. And looking at the specific characteristics of the POT balloon, we can see that this new device is an ultra short shoulder, 0.6 mm. In particular, this length is the lowest actually available in the market. It has an ultra low profile, which is very useful in order to cross and to navigate across tortuosity or calcification. It is available in diameter ranging from 2.25 to 5.0 and in length from 6 to 15 mm. Furthermore, it has a very interesting feature in terms of rated burst pressures, which are very high as compared to other devices. It means that we can use it safely during post dilatation. So what about POT in complex double stenting? This is a case of an old lady with a bifurcation lesion involving the proximal LAD and the ostial diagonal. The takeoff of the diagonal is relatively complex because there is very few room proximally to move the wire toward this segment, this branch. So BMW wire was placed in the LAD, but it was not easy to initially wire the diagonal. So a pre-dilatation with a semi-compliant 2.5 mm balloon was required. And then wiring of the diagonal was performed using a cyan blue wire. Pre-dilatation were both performed at the level of the main branch and of the side branch, and it was decided for a two-stent approach as intention. Culotte was the preferred choice, so a drug-eluting stent 2.5 26 mm was implanted from the LAD toward the diagonal. POT was performed with a 3.08 mm at 12 atmospheres. Then the LAD was rewired. struts were opened, another DS was implanted in the LAD, 3022 mm, kissing balloon was performed, and finally POT was done at the proximal main branch with a 306 mm pot balloon. And this is the final result after culotte stenting on the LAD first diagonal and POT optimization. POT has some important benefits in terms of clinical outcome, as you can see from this data coming from the e-Ultimaster registry. So patients treated because of a bifurcation lesions which received a POT had a lower TLF at 1 year as compared to the counterpart, and similar data come from the EBC main, where patients treated with POT had a lower incidence of the composite of that MI and TLR as compared to the counterpart. So POT is very important even to reduce clinical event at clinical follow-up. What about the Alveo balloon in complex side branch recrossing? So this is a male admitted because of unstable angina. As you can see, there is a bifurcation lesion at the level of the mid-LAD involving the second diagonal branch. Even in this case, the takeoff of the diagonal is relatively angulated, and there is very few room to orientate the wire toward the diagonal. So during the manipulation with a BMW wire in order to wire the side branch, there was a slow flow. So pre-dilatation was needed in order to increase the flow toward the diagonal. It was a risky maneuver because we had also the opportunity to fully occlude the vessel, but the flow was restored, as you can see, after an Apollo non-compliant balloon 225 mm inflated at 14 atmosphere. The diagonal was then wired using a cyan blue wire and then pre-dilated with a 2O semi-compliant balloon. Provisional stenting was decided, so a 275 30 mm DS was implanted on the main vessel. Then POT was performed using a 3O POT balloon at 12 atmospheres, and then the diagonal was rewired. As you can see on the right side of the slide, it was not possible to recross the stent struts using a 2O and a 25 semi-compliant balloon. So I used an Alveo 0.75 mm balloon. As you can see, this new device easily crossed the stent struts. This balloon is available in diameter ranging from 0.75 to 2.0 mm. It has a single central market, and it is available in lengths ranging from 5 to 30 mm. It has a very low profile and a very strong, I would say, proximal end, which has a core in stainless steel and then covered by PTFA, while at the distal end it has a slider hydrophilic coating. All these features allow the balloon to navigate very easily in complex anatomy and angulation. So the wires were opened from the LAD toward the diagonal. A kissing balloon inflation was performed, and then POT using a 3O15 mm balloon at 12 atmosphere was performed on the proximal main vessel, obtaining a satisfying result following a provisional strategy on the LAD second diagonal disease. So in conclusion, POT balloon is a new tool to optimize bifurcation PCIs in complex and non-complex setting. The 0.75 mm Alveo balloon may help the operator to optimize bifurcation PCI in case of complex side branch angles. Those new devices increase the armamentarium available to make the complex easier. Thank you for your attention.
Thank you, Dr. Vassilev, for his brief introduction of port technology and the value of Alveo balloon, both the port balloon and also the new small balloon in teaching a complex bifurcation lesions. One short question for you. So what's your preferred stent technology for the bifurcation lesions?
Well, I've not a preferred device, I would say, but usually I go for several reasons, maybe not very scientific, with the Resolute Onyx device. I feel very comfortable with that stent in several situations and several angulation because of the features of the cells. So that is my favorite device in the setting of bifurcation PCI. Of course, if we discuss about left main and ostial left main treatment in the setting of distal left main disease, I even like new stents, very robust and prone to reduce longitudinal compression. Maybe you know the device I'm talking about. But yes, as I said before, not a real preference, but usually I use the device I already talked about before.
Okay, thank you.
You're welcome.
So the next, you model the next speed.
Yes. So we have as the next speaker Dr. Dobrin Vassilev. Is the president of the Bulgarian Society of Interventional Cardiology and medical director at Medica Core Hospital, Ruse, Bulgaria. He will talk about the wedge balloon for the treatment of diffuse stenosis, new opportunity. So please.
Hello, everybody. I hope you see my screen now.
Yeah, we can clearly see it.
Okay. Just my topic for today will be to show you the newest technology in scoring balloons. This is the wedge balloon NC from BrosMed. The scoring balloon is well suited for osteo lesion treatment, for bifurcation lesion treatment, for long diffuse disease, and for instant restenosis. I will concentrate my cases which follow mainly on the treatment strategy of long diffuse lesions with wedge balloon. Wedge balloon have one long nitinol wire above the surface of the NC balloon, which permits a directed application of dilation force and controlled plaque rupture. But what is unique for this balloon, practically, that there is a lot of sizes, a lot of diameters, starting from 2.0 diameter up to 4.0 diameter, and from 6 millimeter length up to 30 millimeter length. This gives a lot of opportunities for treatment of very, very complex lesions, especially in diffuse disease population. And in combination, I think this is my personal opinion, and it is under evaluation in our center, that in combination with the results which provide drug-coated balloon, and these are results from Piccoletto 2-3-year results, where it was demonstrated that the drug-coated balloons in small diffuse disease lesions give a better MACE, that is less MACE event rates at 3 years in comparison with stenting. And this strategy is further supported from the very recent meta-analysis published in interventional cardiology, which clearly demonstrated that the drug-coated balloons are at least non-inferior according to the MACE event rates in comparison with drug-eluting stent implantation in small vessel disease. Also, that is true for death rates. And numerically, the drug-coated balloon is better in reducing rates of follow-up myocardial infarctions. So our strategy have some support from the recent data, and I will show you how we do that with in patients with diffuse disease, applying wedge balloon and drug-coated balloon. The first case is a 52-year-old male with high-grade angina with a lot of risk factors. He had anterior wall myocardial infarction 2 years ago, but it was not treated invasively. 6 months before current admission, he had an ICD implantation because of the repeated ventricular tachycardia. On echo, the patient had a 46% ejection fraction with anterior wall hypokinesis and normal renal function. The patient had a relatively normal right coronary artery and occluded circumflex artery and occluded mid-distal LAD artery. So we decided to proceed with the PCI on the first on the CTO of the circumflex artery with double lumen catheter and Gaia 2. It was possible to engage the occlusion. Then with the XTR and antegrade dissection, we recanalized this long acute marginal branch. And then this is wedge balloon 12 to 15 millimeters. We directly crossed the occlusion and dilated the whole segment of the CTO. And this is how the vessel looked after preparation with the wedge balloon. We placed a proximal stent at the site of occlusion, and this is the result for the circumflex artery. And then we proceeded with the PCI to the CTO on the LAD with the support of fine cross and Gaia and Ultimate catheters, Gaia 2, then Gaia 3, we were able to cross the occlusion. And then we made several predilations with Alveo 1.5, followed by wedge balloon 25 to 30 millimeters at 6 to 8 atmospheres at the whole length of the LAD. That is the result after the wedge ballooning. Then we inflated 3 drug-coated balloons on the LAD without placement of the stent, and this is the final result after wedge DCB combination of the LAD. The next case is a 76-year-old female with the high-grade angina, risk factors with atrial fibrillation, normal ejection fraction, and normal renal function. This lady had occluded right coronary artery, diffuse disease on the LAD, and high-grade stenosis on the first big diagonal branch, but also very calcified proximal circumflex artery and high-grade stenosis on the distal circumflex. The FFR on the LAD was 0.72, so we proposed for this lady surgery, but she refused definitely. And we decide to make a step-up PCI on the circumflex, right coronary, and finally on the LAD. So we proceeded with IVUS on the circumflex. However, the IVUS did not cross the distal lesion, and we proceeded with the rotablation on several bursts. Passes were done for this circumflex for the proximal part of the vessel and the mid part, and finally it was possible to cross the distal lesion with the burr. And then we proceeded with the wedge balloon 2.5 to 30 millimeter for the distal lesion and the whole proximal segment, which was followed with a DCB balloon 2.5 to 40 millimeters for the distal lesion, and the same for the 275 balloon for the proximal circumflex. And this is the final result for this lady, and she will admit next week for the PCI of the right coronary artery. The third case is 68-year-old male who had effort angina, and the patient had these long lesions on the first marginal branch and the second marginal. That was a really high-grade stenosis. So we decided to proceed with the PCI with wedge balloon 20 to 30 millimeter at 10 atmospheres for the first marginal branch. That was the result after wedge balloon. And then with the drug-coated balloon, 25 to 35 millimeters with quite a satisfying balloon result. So then we treated the second marginal again, first with the wedge balloon, 25 to 30, again distal proximal, and then we inflated two drug-coated balloons for the distal and proximal part of the vessel. These are the balloon inflations, and this is the final result after this treatment. So in conclusion, the wedge balloon is a safe and effective device for treatment of small coronary artery disease. The technical characteristics of the device made it practical application, easy and user-friendly, and the efficacy of wedge balloon plus DCB remains to be established. Thank you.
Professor Ielasi, you are muted, so please turn on your...
Yes, sorry, can you hear me now?
Yeah.
Yeah, okay. So thank you, Dr. Vassilev. The presentation was really very nice and interesting. You showed us very nice cases where you demonstrated the performance of the wedge balloon in the setting of complex coronary artery disease, CTO, and angulated vessel. In particular, I liked the use of very long wedge balloons because this aspect highlighted the trackability of this device, because usually when we talk about scoring or cutting balloons, one of the Achilles heel is related to the trackability, in particular when we discuss about cutting balloons. So sometimes we need it, but we cannot track it up to the target lesion. While in your cases, you clearly demonstrated the very nice trackability of very long wedge balloons. So really nice, very well done. There are actually very few data in terms of clinical outcomes related to the wedge balloon. I participated to a data collection where less than 100 cases were collected. The results in terms of safety were fine, so very few complications related to the device, just one perforation, but not related directly to the wedge, but probably to the procedure because it happened after DES implantation. The device success was almost 100%. That means that the device was tracked to the target lesion in all the cases, and most of the procedure were complex procedure, left main, osteal-located lesion, and CTO. The study was published 1 year ago. And also another very interesting and important application, as you showed us, is the predilatation using the scoring balloon before to DCB PCI in the setting of small vessel or non-small vessel disease as well. So my question to you is related to the DCB PCI. Do you always prepare the lesion with a scoring balloon, or just in some specific situations?
At the moment, as I said, we are running a study where we already included 42 patients. This is our study of our center we are performing at the moment, where we always do scoring balloon predilatation, and in general, I prefer when we will do DCB just to use wedge balloon. We started with this strategy last year, and let's say that I'm pretty satisfied from the immediate results. We still do not have any significant complication, and I hope to remain so. The results in midterm, I hope we will be able to present next year during the EuroPCR meeting, because the sample size of our study is 110 patients, so we are at the middle of the recruitment. So maybe I will be able to give you much more scientific-based data next year.
So is it a comparison study or an observational study on wedge in the treatment of
Still, this is a pilot study, observational, and depending on the result, we plan to do a randomized study next to compare wedge preparation and DCB versus standard strategy of NC or regular balloon predilatation in DCB.
Okay, thank you. And which is the feature you like the most about wedge as compared to other scoring balloons or cutting balloon you used in your practice?
The length of the balloon, because this balloon really give us opportunity to make an controlled inflation and controlled plaque rupture in a long segments, this avoiding more extensive dissection, and this gives an opportunity to do a controlled POBA on the segment. This is actually with this long length and the balloon is quite flexible and trackable, and this gives a lot of opportunities to use it and to do a good preparation without some significant vessel dissection.
Okay, thank you. And do you have a preference in terms of semi-compliant wedge or non-compliant wedge? I mean, do you go directly with the non-compliant wedge balloon before DCB inflation, or?
Always non-compliant.
Okay.
Always sensitive.
Okay, great. So do the other panelists have questions, feelings they want to share?
I just want to congratulate to Dobrin, because my main concern, as Alfonso said, is the deliverability, the trackability of these devices. So it's amazing the cases you have presented, and we don't have this balloon in our center. So amazing, congratulations.
Thank you.
Okay. Dr. Jiang?
Yes.
Do you have questions?
Yes, so actually, in China, we are the leading PI center for the for the market launching trial. So we found this device. It's quite helpful. Besides the length, I think also the crossability and also the pressure. It's very good for this unique balloon compared to other scoring balloons such as cutting or NC. You can go to very high pressures.
Yeah, it would be nice to have even some imaging information after the use of the wedge balloon as compared to other devices, a standard non-compliant balloon or a cutting balloon, just to better understand the role of this single nitinol wire over the balloon. But for sure, the feature I like the most is related to the trackability of this balloon, which is really nice. As I said before, you cannot be sure that every scoring or cutting balloon can arrive at the target site, particularly in the distal segments, as you showed in the first CTO case. So I really like this balloon. We for sure need much more data. So the data you will provide the next year, we hope are very well welcome, as well as some imaging data beside to clinical data.
We have a subpopulation of 30 patients with IVUS. Just
nice.
I didn't mention that, but we made a 13 at the moment patients with IVUS. This is with the high definition IVUS. So maybe next year I will be able to give you much more information about the morphology of the changes in the vessel wall after wedging.
Yes, please. This would be very, very welcome. So I think we can move to the next presentation and the next speaker. So please, Dr. Jiang.
Okay, so our next speaker will be Jinger from the Second Free Hospital of Windsor Medical University. The talk is titled The Value of Non-Compliant Alveolar Balloon in Secure Lesions. Please, Dr. Jing.
Okay, thank you. Introducing from Dr. Jiang, and hi everybody. And today, a great honor for me to present one case, below 0.75 balloon in only one CTO case. And this case, the keyword is the CTO lesion and corner hyper-resistant lesion, and this PCI is a hyper-guided PCI. First of all, we'll see this information presentation of this case. This 50-year-old male has been experiencing chest pain after exertion for 1 month and got worse for in past 1 week. And for his past medical history is hypertension, he's smoker, and have diabetes. The important history is here with unclicked melena. So it's a little bit difficult for us to choose after PCI. We choose DCB or we choose DES. So we also can see the echo data is LVDD is 48 millimeter, injection fraction is okay. And for lab result, we can see the hemoglobin is only 10. So maybe the patient has some problem with melena. So, but the patient has the chest pain. So we have to do the PCI, and we see the ECG. ECG we see not a big difference. We only see some 2-3 AVF leader. We have some small QA. So let's go to angiography. For the right coronary artery angiography, we can see in the proximal, we have some total occlusion. But here, if we have a very good angiography data, with quality, we can find some, maybe they have some very microchannel in the proximal of the RCA. But here in the middle RCA, we cannot say it's really clear it's a microchannel, or we can see bridging channel, we cannot see. So for left coronary artery view, you can see the tiny atherosclerosis from the circumflex, and also have a tiny or mild stenosis in the mid of the LAD. And also from the IAO, we can see some collateral connection from the left coronary artery to right coronary artery to the PDA. And also we can check the collateral circulation and from the left coronary artery to the right coronary artery, and they can continue to the middle of the right coronary artery. So this angiography from first of all. So for strategy for this PCI, we will see the proximal maybe the mic channel, and also here we cannot see very clear mic channel, maybe the branching collateral. So it's not so difficult cases, but also I think here a little bit challenging for us. So from the right to left corner artery, you can see there are CCS2 collateral connection from the, I think it's a septal branch to the PDA. So the plan strategy for me, it's a 3 plan. First plan is because it's GC2 score is only one, because we can see some calcium either in the corner artery, and the only one, and we could try with the first antegrade approach, and second, maybe we will use a parallel wire technique. Maybe we will use the IVUS guided. The second plan, if we cannot cross the wire, so we will choose a retrograde approach with separate collateral constellation, and maybe we use casing wire, or we use a reverse card or AGT, and so on. And then the last plan, I would say, is maybe we will choose a CABG. So according to this plan, we start our PCI. So first we choose a 7 French SAIL 1.8 guide cassette, and we use a core SAIL and 135, and we with run through and run through wire, and we do the, I think with to improve the quality of the angiography. Here we can see a little bit clear. So the proximal RCA, we have some a little bit of micro channel. So I put the run through in the corner branch, and then we change the XTR to check the entry point. It's very easy. The XTR will cross the proximal lesion, but we check the retrograde angiography. We found the wire not in the true lumen, maybe in the intraplug or in the false lumen. So here we found the not unclear entry point, maybe wire, but here wire was stuck in the CT lesion. So one choice is to wire escalation. Also, we can use another technique, parallel wire, or we'll check the IVUS with IVUS to check the entry point. So I choose the last one. I will use the IVUS to the corners branch, and we check the IVUS. It's a POGAC from the corners branch. And here we will see from the 5 o'clock to 10 o'clock, we see the main branch is coming to the vessel. So we will say the wire in the XTR, the wire in the proximal RCA is in the true lumen. So here I will choose another one. So I will use the 1.25 and the 1.5 balloon to dilate the proximal lesion, because the wire is stuck in the CT lesion, cannot change your direction or cannot push too much. So I will use the small balloon to dilate the proximal lesion. And we change it to Sasuke. It's a dual lumen cassette to use the Gaia second to do the parallel technique. So fortunately, it's keep going, and then we check the retrograde angiography. It's very close to our true lumen from a different view to check the position of your second wire. It's very close to our true lumen. So, but here, keep going the second Gaia second, but here the Gaia second difficult moving to the distal, because I think either calcium has a problem with the CTO lesion, and we stuck the R wire. So here I will pull back the Sasuke dual lumen cassette and change the Cosel again. So here we get a much more better support, and the wire very easier close to the distal. But here, another problem is Cosel. Cosel cannot cross the CTO lesion. So here I change it, move back the Cosel, and use the Godzilla, insert the system by the balloon with 2.0. And then I will use the Avalo 0.75 millimeter NC balloon. It's very easy. just push the balloon and keep going. Here, the balloon very easily can cross the CTO lesion, and when balloon was dilated to 6 to 20 atmosphere, and then we change the balloon with the bigger balloon with 1.5 and 2.5 as a two ratio zero balloon. And then I check the IVUS. From distal, the vessel is normal and the small branching come in and there are a little bit small plug. And they keep going and from IVUS, I cannot see too much calcium plug in is sufficient calcium plug. It's a lot of fiber plug. Here another small branch coming. So actually, the CTO wire is in whole distance also in the true lumen. And here you have some small dissection and the intraplug dissection. And also very interesting finding in the from the, I would say in here from the 9 o'clock to 1 o'clock. 1 o'clock is coming. So IPH is a hemorrhage is maybe due to our first CTO wire. So I checked IVUS. The problem is from this toe, the right conduct is not so big. It's only 2.25 millimeter, and in the CTO body, it's only 2.5, and in the proximal, the RCA is 3.0. So the problem for me is that now we have to choose the DES or DCB because the patient has the melena, D3, and the hemoglobin is a little bit decreasing. So we have to check it, and also we have to reduce the DAPT duration. So first I use the scoring balloon 2.25 and with the 6 to 12 atmosphere, and then I use the 2.5 NC balloon to dilate the whole CTO body. And then I will check that again to confirm there are no big dissection or hematoma in the right coronary artery. Because during, I think in 3 years ago, from 2019 to 2020, I started in CRF, America for the IVUS imaging. So I did a very small experience, like study. It's to confirm which candle dissection with the candle hematoma will get the acute occlusion. So it's a very important, interesting for us because for the first presentation, we can see we use a wedge balloon to dilate the vessel, and we also can check the IVUS to see if there's a very dangerous hematoma or dangerous dissection. So my finding is for my study is one is if the hematoma is subintima or intraintima. And the second one is if the dissection, the distal of the dissection or distal of the hematoma, they are a small branch or they have heavy plug induced. So it's a finding can for us to have this kind of information, which candle dissection we have to get a bailout DES, and which candle dissection we can leave it and just use the DCB. So for this case, we check the IVUS again, and there are no very big hematoma and no big dissection, only intraplug dissection. So the MLA is here already 4 millimeters square. So after this, I will use the DCB. I have a DCB with 2.5 and 38 meter due to potential melena. So for the DCB, if the patient has some problem with the melena, we can stop the DPT duration. So I think it's a good result for the patient. And this one is a final result. Also, we have some residue, the stenosis in the proximal. So I will check it again, and maybe 3 months later, I will check the angiography again and see if we have to implant the DES or not. Okay, thank you very much.
Thank you, Dr. Jing, for a very nice integral CTO case, which shows the value of parallel wide technique and also the IVUS guidance before the DCB use. And actually, on the IVUS image, you can see clearly, the wedge. We can clearly see the controlled dissection caused by the wedged wire over the balloon. So I think for this kind of small vessel, DCB will be better compared with drug eluting stent. So any comments from our other panelists?
If I may, just in such as maybe in the vessels 2.5 and less, it is wise to do at least to try to make a good balloon angioplasty. Then if the result is good, to apply DCB and not avoid stenting. Just maybe that will be the future, because placing long stents in small vessels, at least in our experience, is the long-term results are not satisfactory.
Yeah, thank you for your comment. I agree with you afterwards, because if we do the DCB or we do the predilated lesion, so we have some problem with it. We try to get a much bigger lumen, but otherwise we have the much dangerous or much damage to the vessel. So it's sometimes not very easy to make the balance. So for me, I would say it's a 2.75 balloon or maybe 3.0 balloon is much better for this proximal lesion. But sometimes if you use the too bigger, we get much more dissection, or you get the hematoma. But we already use the Scotting balloon. Scotting balloon is already, I think, can get a much more bigger lumen, and then we'll get a less dissection. So much safety for this patient. I would say maybe if I try later, 3 months later, I will check angiography again. I will do maybe, as that if the patient have not problem with the melena, I will use it. Maybe DES, maybe I will try much bigger balloon to dilate to get a much bigger lumen.
Yes, well, I have a comment and then a question. So first of all, you clearly showed us the role of the Alveo balloon, which was fundamental in order to have an angiographic and clinical success for the case, because without that balloon, probably you would have not been able to complete the procedure, at least using standard devices, I mean balloon-based device. So this is the first comment. So very nice demonstration in a complex setting such as a CTO. Well, the second one is related to the antiplatelet strategy. Did you use just one antiplatelet agent, correct? Or two?
Two.
Okay. So this is another very, very interesting point, and there is an open discussion about the antiplatelet regimen after DCB in patients at high bleeding risk. Last month, it was published case series of 107 patients treated with DCB in the setting of a high bleeding risk. These patients have been treated with only one antiplatelet agent, aspirin or clopidogrel. And if you look at the result, they were very, very interesting, because the cardiac-related mortality was very low, almost 2%, and not related to the antiplatelet regimen. All MIs were around 7%, and MACE less than 10. So this is a very interesting topic, and probably in the future some more informations are needed, because we are treating patients much more complex than in the past, particularly from the clinical point of view. So have the opportunity to give them just one antiplatelet agent after DCB inflation is something very important. And then the question for you is related to the follow-up of these patients treated with a DCB only strategy. Do you usually perform an angiographic follow-up after this kind of procedure? I mean, CTO recanalization and then DCB inflation?
Yeah, basically for us, if you do the DCB in the small vessel or a big vessel, basically we use a very small vessel, less than 2.5 millimeter vessel. And if the very interesting for this case where I have to check the angiography after 3 months immediately, basically we will talk to the patient to get a follow-up at least 6 months. In 6 months, we will do the angiography again to check the result. If they're not good, then maybe we treat with DES, or maybe we get a much bigger balloon to dilate the vessel.
Okay. And in your experience, which is the rate of bailout stenting at follow-up?
Basically, for us, like Dr. said, we already have some. If for my experience, I have done 100 DCB and at least less than 2% of the patient with a bailout DES. So this is very interesting. It's interesting. If you would like to get much bigger some lumen, you have some damage to the vessel, and then you have to much more percentage to get the DES for the bailout. So if it's a very small vessel, I would say maybe use a scoring balloon. At the first, we get much bigger lumen, and then I will use a very small atmosphere, for example, for 2 ATM to the 4, 6, not too much. If it's too much, and I think we will get much bigger dissection. Even use the NC balloon. The NC balloon, I will use less than 12 atmosphere. If too bigger, I will say it's a little bit dangerous for the dissection.
Okay, and from a practical point of view, when you do DCB, PCI, and you have a minor dissection or an intermediate dissection in terms of the extension, do you use some functional assessment or just imaging?
For me, I would like to use imaging, prefer to use a functional or physiology method. Right now we have a lot of methods to check the FFR, or you use the residual FFR. But sometimes the FFR very difficult to control. If you already have some dissection or hematoma, it's very dangerous to, maybe we'll get worse for this vessel. But basically for me, I will use IVERS and prefer to the OCT and to check if there's some big dissection or big hematoma. Or if the TME flow is bad, and no doubt we will use the DES. But if the very small dissection and also the distal of the dissection, there are a lot of plaque or maybe some calcium plaque, and also have the bigger vessel, because branch, I would say, okay, it might be safety for this patient not to get the acute occlusion.
Okay, thank you. Thank you, very interesting. So if we have no other questions, we can move to the next speaker. Next speaker is Alfonso Jurado. He is an interventional cardiologist at La Paz University Hospital in Madrid, Spain. He is also an expert in CTO PCI procedure, and he is a Euro CTO club member. So please, Alfonso.
Thank you for the presentation. I don't know if you are seeing my screen.
Yes, we can.
Yeah, thank you. So first of all, thank you to BrosMed, World Medical, and all the previous speakers for having me in this meeting. I was asked to prepare a case to show the benefits of Alveo balloon in general in complex PCI, and I was sure that you were presenting spectacular cases, and I was right. So I'm going to present one case. Yes, it's not the most spectacular one we do in CTO scenarios, or complex PCI, but I think it illustrates very well the main advantages of this balloon in this setting. So if I can, so to show this, I would like to start with the conclusions. Just to remark the things we are going to see in this case. The Alveo high pressure balloon combines several technologies, but it gives it mainly two advantages from the against the competitors. It is a taper ultra low T profile that gives it superior crossability, as some colleagues have shown before. And also the material, the design is resistant and permit high pressures in the inflation. So it's a great tool for the complex PCI we are seeing in this meeting. The case I'm going to present is a 74-year-old male with a lot of cardiovascular risk factors. He was diabetic, hypertension, a chronic kidney disease, and his coronary history started some months ago in March 2023 with unstable angina. He was admitted in our hospital and underwent a coronary angiography that showed a 3-vessel disease. After the Artimes meeting, PCI was decided. So LAD and proximal circ were treated with drug-eluting stents. And the patient had also a CTO of the right coronary artery, and conservative treatment was decided at that moment. The patient was discharged with normal left ventricular ejection fraction and optimal medical therapy with dual antiplatelet treatment. However, 3 months later, just a few weeks ago, in June 2023, the patient suffered again unstable angina and was admitted again. And I'm going to present you the angio, if I can, of the last admission. So this is the angio. You can see the stent in the proximal. You have the still image in the right part of the screen. You have the stent and the circ that looks quite good, similar than the last result of the previous PCI. The stent is jailing this marginal branch that has a critical lesion in the proximal part. The ostium of this side branch is healthy, but it has this subocclusion. And the stent in the LAD, it's also okay. This patient was included in the multivessel talent trial, so all the PCIs has to be performed with intracoronary imaging guidance. So we have the IBUs of the previous PCI and the stent were well implanted. This is the result of the LAD stent. The diagonal is okay as well. And thinking about the reason of these new symptoms, to be honest, we don't know if the symptoms are new or are the same symptoms of the previous admission. The patient has also this CT of the right. We have the same collateral circulation, and these difficult to see mild to moderate lesions at distal left main to ostial LAD that the intermediate branch are difficult to see. So thinking about the case, that the image of the angiography is quite similar than the final result of the previous one. We decided to evaluate the left main and the LAD with IBUs. This is the pullback from the LAD. You are seeing the stent in the LAD. That is quite good. There are some mild under expansion at some point, but the main problem is not in the stent. It's in the proximal part of the vessel. Probably I'm going to advance the video. It's here. You have the still image in the right part of the screen. The proximal LAD and also the ostium has this plaque, not severe calcification, but the plaque burden is important. But it is quite similar than the previous IBUs 3 months ago. So we, of course, measured. I'm going to advance the run. This is the plaque in the LAD. This is the wire in the circ. And the left main was okay with a minimal luminal area over 10 millimeters square. So we measured the area at the LAD, and this is the value, 5.6 millimeters square. I don't know your opinion at this point. You would proceed, because we don't know if the symptoms are caused by this lesion. The patient has also a CTO and also a critical lesion in the main marginal branch of the circ. So I don't know if you want to comment something here, or I move.
Well, it's not easy to decide, because it is something like a borderline. It is critical if we look at the cutoff of 6 millimeters square at that point, but of course the patient has also another lesion. So really difficult to decide. Don't know if you went for a physiological assessment or if you moved to the CTO. Not easy to decide.
No, exactly. We are in the same mood.
Just to comment, the physiological assessment in this situation will be not
easy to interpret.
Not significant, because there is a distal lesion, so the distal resistance will be high, and it will be falsely normal. And we can accept the physiological assessment in this case only if it is significant, but if it is above 0.80, there is no value in this case.
I don't know if no value is there are big words, but probably it is not easy to interpret. I agree, fully agree, because of these things about the distal lesions. Also, the patient has some disease in the left main, and also the AD is giving some collateral circulation to the right coronary artery. So all of these factors make it difficult to interpret the physiological assessment. But we did it just to complete the study and to decide to treat this lesion, the circ, or the right coronary artery CTO. So this was the IFR result, 0.92. So at that time, and taking into account all the considerations you have done, we decided to perform this plan, to be conservative at the LAD at that time, perform an ad hoc PCI of the critical or subocclusion of the marginal branch that was jailed by the previous stent, and then plan a CTO PCI of the right, and then reevaluate at that time the physiological assessment of the LAD. So I'm going to present the PCI of the marginal branch, because the CTO PCI is going to be done tomorrow. And this is the PCI that I hope that shows the benefits of this Alveo balloon. As you see, we went with a radial 6 French approach with an EBU guiding catheter that gave us not the best backup in the world, as you can see here, because of the tortuosity of the subclavian artery. We could cross the stent, the side cells of the stent, towards the marginal branch with a Scion black wire. And this is the Alveo 0.75 by 10 millimeters balloon that crossed quite easily the cells of the stent, but was stuck in the subocclusion of the branch. That, although in the angiography seems not to be very calcified, the IBUS afterwards confirmed that the calcification was at least moderate. So we decided to inflate the balloon at this site over the rated burst pressure, 24 atmospheres, and the balloon was broken at that time without any complication. The flow improved a little bit, and after that we have a lot of confidence in the Alveo. So we try to cross with a bigger balloon after this initial inflation and rupture the 0.75. This is the 1.0 Alveo balloon, struggling to cross, and then we retrieve a little bit the balloon, gain some distance, and then the balloon crossed, as you can see here. At that time, we inflated the balloon at the rated burst pressure, 20 atmospheres, and the balloon inflated well. And after that, we could easily cross a 2.0 balloon. I don't know if you remember that the stent in the proximal to mid circ was 2.25, guided by IBUS. So we thought that 2.0 balloon was a proper size. the expansion was okay in both projections. So we decided to implant an stent here. Probably it would be a good case for a drug-eluting balloon, but at that day, we hadn't the proper sized drug-eluting balloon in the CAD lab. So we decided to perform, to implant a stent, a drug-eluting stent. In this case, as the patient was diabetic, I don't know if you have read the sugar trial, but we decided to use the CREATE stent because of its benefits in these patients, and also because of a practical advantage that if you have this balloon, it has 2 markers at the edges of the stent. So there are 4 markers, radiofide markers, at the beginning and at the end of the balloon, and also at the beginning and the end of the stent. So it's quite interesting to adjust the stent to the ostium of the side branch because it was healthy. The lesion was a little bit distal, and not to protrude in the proximal part of the circ. So we implanted the stent. This is the final angiographic result, and after that we checked with the IBUS. You have the pullback here. You look at the classification, the distal part, there is no dissection. This is the stent. I'm going to move it a little bit faster. The result was okay. This is a very small vessel disease. Probably a drug-eluting balloon could be had been a good option here. And you are seeing this image of the stent in the circ and the stent in the marginal branch here without any protrusion. That was our intention at that time. So the Alveo balloon could cross, and also you can see the inflation at high pressures over the burst pressure in the first one that was ruptured, and at 20 atmospheres in the 1.0 Alveo balloon. So I'm going to be fast with this review of the Alveo balloon, just to mention the main advantages of it. Probably the best one is the crossing profile that could be the smallest in the market. This is due to the design, the distal tip design, that is optimized with the laser technology and maintains the flexibility that, as you have seen in these cases, and probably produce the smallest crossing profile compared with the competitors in this setting. If you can see these images of the Alveo 0.75, the transition of the distal tip and the transition with other small devices, it looks beneficial. And also we have some data, laboratory data, of course, comparing the tip and crossing profile, the transition between the tip and the balloon of the Alveo and the competitors. And not only the tip and the crossing profile, but also the balloon itself, because of the material that this is developed, it has a very good flexibility and a crossing profile. And also, the good point is the combination of this crossability and the high pressure you can achieve with this balloon. You can go up to 20 atmospheres. Probably in the first balloon we went a little bit superior with the pressure, 24, 25, and we ruptured the balloon without any complication. And probably the average blood burst pressure is 28. So half of the patients half of the balloons are going to be broken if you achieve this pressure, but the result is quite good. Also, the design of the balloon permits a very good rewrap of the balloon that is beneficial in this lesion that we are advancing, retrieving, advancing, inflating, and deflating several times. And other advantages I'm going to finish is the sub design that is performed to give us optimal delivery, and also a very low profile that is compatible in the CTO scenario with other devices in 6 French, with very good pushability, as we have seen in this case. Just as an example, the pushing force required to do these curves and cross a lesion with the Alveo balloon and the competitors is much less with the Alveo than with other devices. So I finished with the same conclusions I started with. The Alveo balloon is a very good device because of the crossability of it, and also the resistant design that permit high pressures in this complex setting. Thank you for your attention.
Thank you. Thank you very much. It was really a very nice presentation. I fully agree with your strategy about the left main LAD disease. Then you faced with a complex situation, and Alveo performed very well. In particular, you clearly showed the safety of the device, in part the 0.75 mm balloon inflated at 20 atmosphere, even if the balloon broken. No main complications occurred. You did something like a shockwave at that point with that kind of
plastic.
Yes. But was, I mean, very, very nice and impressive, because later you were able to cross with a 1.0 Alveo balloon. Even the performance of this device was really very nice. So actually, there are not so many extra small devices. If I will remember, there was in the past at 0.8 mm in diameter balloon manufactured by a Swiss company. I had very few experience with this device because it was very expensive. While with Alveo, I feel really very comfortable in the setting of angulated side branches, calcifications, or CTO. So really, really nice. So among the features you highlighted, which is your preferred as compared to other small or extra small balloon? The strength of the tip, the crossability, the possibility to inflate the balloon at high pressures?
I think it's the crossability, because you can use high pressures in several devices. Probably the description of the company is this, but the crossability of the device is quite good. We have several cases in which we use other devices, other balloons, a small balloon to cross, and after that the Alveo crosses. So I think the crossability is the main feature I like of this device.
Do the other panelists have comments or thoughts to share about the Alveo, the experience?
I absolutely agree about the crossability. We had a case, actually that was last year during our conference here in Rus. During the live case, I was not able to cross lesion with the rotablator, even 0.25 with 125 burr. And then I was able to cross it with 1.0 Alveo, which actually resolved the case. And at the moment, for me, Alveo is probably the best balloon which we have on the shelf for this type of cases.
No, I fully agree, and we are doing a lot of rota, laser, and orbital in it. But if you have a stent and you have to cross the side cells, probably you need a balloon. We have had in this case laser in mind, but if you have this kind of balloons, this kind of small devices, they save some cases.
Absolutely.
Yeah, absolutely agree. It's a very, very nice device. A new device we have in our armamentarium, and it can help us to face with much more complex situation and to solve even frustrating situation, because there is nothing worse than to cross with the wire in a very resistant lesion and to be not able to cross with other devices. So as you nicely mentioned before, you need to dilate with balloon even before to go with some debulking devices. And so this Alveo, particularly the small and extra small sizes, really can help us to overcome some complex and even frustrating situation. So we can move to the next speaker. The next presentation will be released by Dr. Claudio Cigalini. He is an interventional cardiologist, head of the interventional cardiology at the treatment service at CETE hemodynamia at Rosario, Argentina. So Claudio, please.
Hi, good morning and good afternoon to everyone. We have two cases of complex situations using BrosMed balloons. Because I am actually in another meeting, the first case will be presented for my son. He's an interventional cardiology. Yeah, he's an staff at our CAD lab. And soon I will be here with you.
Okay. We can see the screen, but we cannot hear the voice.
Now, can you hear me?
Now, yeah, we can hear you. Please.
Okay, sorry about the technical difficulties. I'm going to present a clinical case entitled Empowering Cardiologists, BrosMed Advancements in Complex PCI. This is the clinical case of an octogenarian patient with hypertension as the only cardiovascular risk factors, but had lots of medical history. He had heart failure with reduced ejection fraction and moderate aortic stenosis, paroxysmal atrial fibrillation, and a chronic kidney disease. He was admitted with NSTEMI, with ST depression on the lateral derivance. When we performed the angiogram, we could see a total chronic occlusion of ostial RCA, a very severe lesion in ostial LAD, a concentric and focal disease, large diffuse disease in the left circ with the total chronic occlusion of the first virginal branch at its ostium, and good collateral development to the RCA. In this cranial view, we can also see a very tight stenosis at the bifurcation of the LAD, of mid LAD with diagonal branch, which had quite severe stenosis at its ostium. So we wanted to keep it simple. It was a very complex patient with reduced ejection fraction, moderate aortic stenosis, and double bifurcation lesion. So we decided to go right radial access with a backup left 6 French guiding catheter and try to perform an IVUS guided provisional stent with both rotablator and intra-aortic balloon pump assistance standby. So the procedure was not that simple because of tortuosity of the subclavian artery, but we could manage to perform all the procedure through right radial approach. First, we crossed 2 wires to LAD and to the first diagonal branch and performed predilatation with Apollo NC balloons at high pressure with good expansion, both in the bifurcation of the LAD and the first diagonal branch and in ostial LAD from the left main. Because side branch compromise, we have to predilate with also a small NC balloon to the diagonal branch, restoring flow, and perform IVUS assessment of the LAD, showing an eccentric calcified plaque after the diagonal branch, and then a very severe calcification with concentric calcium in LAD, and a very nasty ulcerated plaque. Now we're going in the ostium of LAD, this in the left main. Here are the reference diameters. So after this, we decided to go with an optimization of the preparation of the blood with an NC 3.5 Apollo balloon with good expansion of the balloon, and afterwards an implementation of a biodiagonal polymer sirolimus eluting stent across the diagonal branch with POT performed with the POT PCI balloon. Here are the stent beast images in order to show the good result. This is not the position where I perform POT. This is only to show you the difference in the caliber after POT and then the need to optimize also on the proximal part. And you can see the short shoulders as described previously, this balloon, which makes it very easy to perform a decent POT. And after that, I continued with the left main to LAD stent implantation of the drug-eluted stent, with final POT with a 4.5 POT PCA balloon. This is the final IVUS. Good expansion despite severe calcification, and good apposition of the stents, both in the LAD and first diagonal and left main to LAD. And the final angio. a simple example of how new devices can simplify our work and make complex procedures simple. Thank you very much for this opportunity.
Thank you. Do we have also a second case we can discuss and then?
Yes, Claudio is to present the second case.
Okay. So thank you. The case was really amazing, very complex in terms of anatomy, but even because of clinical features of the patient. So the question is related to the patient and the anatomy. So do you usually perform this kind of high-risk procedures without a circulatory mechanical support device? Even on this side, you prefer to be simple, or it was just a decision related to other issues, peripheral artery disease or other?
No, the only left ventricular device we have in our institution is intra-aortic balloon pump. We decided not to go with this kind of device up front, but we had everything placed and prepared if needed. We performed the case with short inflations in the left main to prevent hemodynamic collapse, and the patient related very well.
Yeah, the case was very, very nice. It was complex, but you easily managed it, and the final result was fine, just with a provisional approach on the diagonal branch and on the left circ. So really, really well done. And what about the other panelists? I mean, do you approach this kind of cases routinely with a support device, or you even do this kind of procedures without any support?
If I may, in our center, it depends the ejection fraction, the age of the patient, the femoral arteries, and the complexity of the procedure. And we always comment the case with the acute care unit that support us, and then decide. But we have a low threshold to use mechanical support devices.
In general, in our center, if the patient has an ejection fraction less than 50, I will place him or her on a balloon pump or IVAC, depending on the size of the femorals and the iliacs. And in patients with ejection fraction more than 50, it will be on just ready for insertion. This is our strategy.
Okay, so you leave a sheet at the femoral site, and then in case you put as a bailout. Yeah, this patient was, very complex, even because of the moderate aortic stenosis, reduced ejection fraction. So, probably it is a good patient for a mechanical circulatory support device in case of good femoral access. But yeah, the procedure was performed nicely, safely as well, and the final result was really, really impressive. Even the pot balloon was used. It was nicely shown as this very short shoulder balloon can help the operator to optimize stent implantation at the proximal main vessel. It is important to highlight the correct position of the balloon just proximally to the carena in order to respect the geometry of the bifurcation. So the case was really nice, really well done. So congratulations. We can now move to the other presentation. Dr. Cigalini, Claudio,
yes,
please.
Can you see my screen?
Yes, we can.
Okay, we have another complex case about an 84-year-old male with history of high pressure and dyslipidemia. He has history of minor stroke in 2020 and no other comorbidities. He was hospitalized because of new onset class 3 angina and dyspnea with a complex ventricular arrhythmia, new bundle branch block, left bundle blood block, and he had also depressed ventricular function. This is the first angiogram where you can see a very diffuse disease of right coronary artery with moderate calcification, very tight here. And we also can see a severe lesion at the circumflex and a very complex lesion with an aneurysm formation of the LED. Here we can see better, also with some tortuosity, very tight lesion, very severe calcification of the LED. So in this case, we decided to do a step procedure, starting at the first procedure of the simple of the more simple arteries. So in the first step, we treat the right coronary artery and the left circumflex. We predilate the lesions with Apollo NC balloons. We haven't got any difficulty to cross. We could prepare the lesion very good with high pressure insufflations. And after that, we implanted 2 sirolimus elutus stents with this final result. Because of the complexity of the patient, we decided don't treat to this posteroventricular lesion. In the same procedure, we treat the left circumflex. We had some difficulty to cross the lesion, so we have to go with a CTO wire. And we could cross with a balloon at Artimes 125 by 15 millimeters. And we finished the preparation with a predilatation with Apollo balloon 2.5 by 20. And after that, we implanted a sirolimus eluting stent with this final result. So we wait 15 days to allow the patient to recover. The patient improved his symptomatology, and the arrhythmia was controlled by with amiodarona. And 15 days we done the second procedure. We go to by radial access with a 6 French, and in this case we choose to do a rotational atherectomy. We need to cross the lesion with a microcatheter to exchange to the rotor wire, and we do 2 ablations with 1.5 and 175 bore. After that, we do IBUS. This is the measurements, and you can see the severe calcification concentric here. After that, we implanted 2 everolimus eluting stents. The distal 3.0 by 38 millimeters, and the proximal 4.0 by 32. And after that, we do pot with a pot balloon. Here we are looking for the right position. We use this kind of imaging, the stem vessel beast, to ensure the right position. And after that, we noticed that the ostium of the circumflex was compromised. So we do kissing balloon here. And after that, a new pot. The ostium of the circumflex looks better. And the stent of the left main looks well appositioned. We have some bad apposition at the area of the aneurysm, right here, but in the rest of the segment and also of the left main, the apposition was good. And this is the final angiographic result. The patient now is okay, it's asymptomatic, and the ejection fraction increased to 45, 30 days post the last procedure. Thank you very much.
You're muted, Alfonso.
Sorry. So I was saying thank you very much for this case, because it was really amazing, complex in terms of anatomy, because the patient was a multivessel calcified disease, and even from the clinical point of view, he was a very sick patient with a severely depressed ejection fraction. So I fully agree with your strategy of step procedures, starting from the easier, even if was not really easy, even the RCA and the left circ. You showed us nicely the performance of both the Artimes balloon, which is another balloon manufactured by BrosMed, and the POT balloon. So really, really well done. Even this case without mechanical circulatory support. So even in this case, for this case, congratulations, because actually in Italy or in Europe, or I would say in the Western countries, there is a lot of talk about the support for this kind of high-risk patients. So it is not so common to approach these cases without support, but you showed us that you can even be successful. Talking about the pot or the Alveo again, or even the Artimes, which is your feeling related to the refolding the balloon, particularly in such a complex procedure? You can use many times the same balloon. So do you feel the refolding fine? I mean, you can use the same balloon more than twice, 3 times, or it is similar on this aspect to other balloons?
I use the same balloon for this case, and I used to fold by myself for the second pot, because I think it's better. I have in a couple of cases some difficulty to recross, and I used to fold with my fingers the balloon after the second pot.
Okay, so you are almost always able to reuse the same balloon several times.
Yes.
Fine. This is another very important features related to this device as compared to other. So are there questions from the panelists, comments to the case?
If I may, are you use Claudio to use 2 bars in the procedures with rotational atherectomy, or because we are moving to the rotatripsy technique to use small bars and then complete with rotacutting or rotatripsy with a shockwave? I don't know if you do the same, or you use a lot of times 2 bars in the same procedure.
No, it's exceptional for us to ask more than 1 bar. in this case, I felt I couldn't cross with the IBUS catheter after the 1.5 birth, so I decided to go directly to a more aggressive ablation. But it's not common at all.
Thank you.
Do we have other comments? Okay, so if there are no other comments, please, Dr. Jiang, you can conclude the session and the webinar. It was very nice cases, very nice demonstrations about the performance of new devices, Alveo and pod balloon in particular, used in several settings, CTOs, bifurcations, calcified lesion. So it was really nice to share this case with you. And yes, yes, please, Dr. Jiang.
Okay, thank you, Dr. Ielasi. You already concluded the whole session very nicely. I think this session will be very educational for our colleagues worldwide. We have very nice cases like bifurcation, calcified lesion, CTO, and also some lesion you need to cross the stent strap. So which shows the advantage of new devices from BrosMed. Actually, this kind of device will make the complex procedure much easier and safer. And thank you for all the experts and all the discussants. Thank you. Maybe it's time to close the session.
Yes, so thank you very much again. It was, again, very nice, and hope to see you soon to share other case and comments in the next future. Thank you.
Okay, see you. Bye-bye.
Thank you very much.
See you.
Bye.
Bye.
Mm.